Good morning. Let me start by saying a big thank you to the organisers of this meeting for the invitation, and also for their hospitality to me and the other speakers since we arrived. It's been great, as always in Athens. The reason I'm talking about this is my view on intensive care finance and budgeting has changed with progression in my career. I started as a surgeon, became an intensivist and spent 13 years in the Netherlands as Chief of Intensive Care in Maastricht, and since then I've been a hospital director, Chief Executive, and I'm now in the Department of Health doing policy work. And it's about the impact of the global economic downturn on the likelihood of us getting the financing we need in the future for intensive care, and then some thoughts on what we can do about it. Focusing on Europe, not the US, but Europe's a diverse place, and the countries have very different economic situations. Only too well known here, of course. The problem is intensive care is an expensive asset. Typically, it's 10% or more of an acute hospital's budget. 10%. So in my last group of hospitals, £260 million a year, £28 million was spent on critical care. Many countries are suffering from significant national debt. I'm told that salaries have come down in Greece by 40%, but prices have gone up by 10%. That's an untenable situation. And I really enjoyed Paul's talk on ICU design, but how much of that is gold standard and unachievable given the finance and economy in the future? I opened a new hospital in mid-Essex. The cost under private finance initiative was £145 million, and that meant a unitary payment, or a mortgage payment if you like, of £1.4 million a month in a hospital with a budget of 260. So £14 million a year was just disappearing in interest payments. It's not only Greece that's in trouble. Many countries have got a national debt that exceeds their gross domestic product for the year. Italy has a national debt of 1.3 trillion euros. That's massive. Spain, 22% unemployment, and almost double that in under 25s. Deep recession. So as I said, many countries have a national debt that exceeds gross domestic product. That's not going to be solved in 1 or 2 years. It's going to take longer. And let's just think about what that means. If you were offered an extra year's salary just suddenly, but it wouldn't clear your overdraft in the bank, how would you feel? Because that's the situation that our countries are in, and that's why Standard & Poor and other rating companies are down-rating some of these countries now. But they were a bit slow to do that. I know more about the UK, so let me just give you some facts there, but you can extrapolate it to your own situation. Public borrowing in August last year, and I just happen to know the numbers for that, in the 1 month was £15.9 billion. That's £250 for every resident in the UK, man, woman and child. The interest on that debt is £160 million every day. Now, if you get a down rating by Standard & Poor from AAA to a lower one, you will have to pay more for your interest, significantly more. So £160 million each day might double. And that's what's happening in some countries now. The NHS, the health service in the UK, is entirely government funded. The government decided, and I don't know why, because they cut every other public sector to protect healthcare funding up until 2014. Historically, the NHS has enjoyed growth in its financing of 7% a year. A flat budget until 2014 means a saving of 23% is required. The government then decided in their comprehensive spending review last year to award an extra £10.6 billion to healthcare at a time that every other public service, education, social care is being cut. A pay freeze for all staff in the NHS earning over £21,000. They've saved 33% in management costs since last year in the regional health authorities, but we still need to save £23 billion by 2014 to balance the books. So that's the background to the finance. We're not going to get any more. We'll probably get less in the future, at least for the next 4 or 5 years. And that's at a time when we're expecting the number of admissions and the number of elderly patients to intensive care to go up significantly. I don't know, Jeff, if you can remember what ICNAC came up with, but I think it was in 15 years it would go up by 20 or 25%, something like that. Doesn't matter. It's going to go up dramatically. The costs of treating these elderly patients undergoing more technological procedures will greatly increase. More than 70% of your staffing costs, total costs, will be staff. Therefore, that's where you've got to look to influence your intensive care costs. Now, I know that in some countries they're short of intensive care nurses, but in the United Kingdom and in Canada, we have one nurse for every intensive care bed 24 hours a day. But if I walk into intensive care at 3 o'clock in the morning, there'll be one nurse at the nursing station and 7 or 8 in the coffee room. They're an expensive resource. In the Netherlands, we had 3 units of 10 beds. During the day, in the morning, we had 10 nurses for each of those 10-bedded units. In the afternoon shift, that dropped to 8, 7 and 7. And for the night shift, it dropped to 7, 6 and 6. And that worked perfectly. We never had trouble. The extra nurse on one of the 3 units was a floating nurse that would go to help out on a unit if there was a major problem or an admission was coming. Now, moving to that from one-to-one nursing, which is what we have in the UK, would save about £1 million a year for a unit of 10 to 12 beds. I would recommend that you start calculating the nurse hours per patient day, because what we found was they were asking for one nurse for one bed, but they weren't counting the nurse manager, or the audit nurse, or the practice development nurse. So we actually had 13 nurses for 10 beds. In the Netherlands, they were all included. They worked in the morning shift and they were free to do their research and practice development in the afternoon. It's important to look at flexible contracts. If you have a quiet day, your unit's not full, you don't want all the nurses coming to work. One way around that is to have what the UK calls bank staff. Not agency, which are very expensive, but bank staff. Preferably your own nurses, but people that are able at short notice to come in to do an extra shift. That way you can flex your workforce. And then medical staffing. I'm frankly, appalled at the number of intensive care doctors on the average intensive care in the UK now. I spoke to one intensivist that I won't name here in the audience, and there are 7 intensivists working in the unit, and they work 1 week in 7. That means 6 weeks in 7, they're not doing direct clinical activity. Of course, they'll be doing audit and research and teaching, and they'll come in perhaps for grand rounds. I'm not saying they're doing nothing, but are they profitably employed at a time that we can't afford them? One way around it, the way we worked in the Netherlands, was we had 3 full-time intensivists for the 30 beds, and all the other intensivists were part-time, working part-time in a parent specialty, anaesthesia, medicine or surgery. 12 in total for 30 beds, so a very small number compared to some of the UK units at the moment. On a day that they were on call for intensive care, they worked full-time in intensive care. And they would have to come in the following morning for the round to hand over. But that was a much more cost-effective model than having 7 full-time intensivists for 10 beds. Things like your drug budget, actually, You've got to look at it and get your top 10 drugs every month from pharmacy, but you're not going to save massive amounts of money because most of your costs are staff. David, I really liked what you talked about intelligent ventilation yesterday, and it made me put in an extra slide. Another way of using less staff is to require less beds. And if you can reduce your length of stay through intelligent ventilation, as David talked about, weaning protocols with sedation vacations, good sedation policy, ventilated bundle to prevent ventilator-associated pneumonia, and run the unit 24 hours a day. If you are in a luxurious position of only working 1 week in 7, split the week up and do 2 or 3 days. And then work until there was nothing else to do during your shift. Instead of doing a ward round at 10 o'clock at night and going to bed and waiting to be called for an emergency. It's an expensive resource. Patients come in 24 hours a day. It should be run 24 hours a day because currently we're not weaning patients between 10 p.m. and 8 a.m. Not actively. The doctor's not there helping the nurse make decisions. Depending on how you're funded, you might still be profitable on paper. But even if that is the case, even if the tariff or the payment to intensive care means that you're earning more money than you're spending, you still need to help your organisation to hit its bottom line, to meet its financial targets. You're responsible for 10% or more of the hospital budget. The hospitals are going to have significant cuts in their budget, therefore help them to save money. One thing you should be doing is doing a monthly variance analysis. You know your revenue, you know your personnel costs for permanent, agency and bank. You get your drugs bill, you know what you've spent on supplies and sterile supplies. You've got your workload index, that's the nursing hours per patient day, and the acuity of the patient, and you're aware if there's been any issues like an outbreak of influenza that would influence your costs. And then you get your net financial position for that period, the year up till then. So you've got a variance for the current month, a variance for the current year, you've got the reason for the variance, and only then are you in a position to defend your cost to hospital management. And you should be seen to be taking action when there is a variance that can't be blamed on a major issue. I'm on a hobby horse today, and I apologise for that. But junior doctors in intensive care medicine. The European Working Time Directive is the worst thing that ever happened to healthcare. We used to get juniors from surgery, from medicine, from anaesthesia, and from respiratory medicine, and they'd come for 6 months. And after about 2 months, there were useful individuals that could actually help you run the unit. If you're now a big academic unit, you've got fellows, the consultants have some support. If you're not, you're essentially working on your own because people that come for 2 or 3 months are not interested. Now, a surgical trainee who's limited to, say, 40 hours a week has to get a certain number of operations. But they don't have time to do ward work, so the very junior doctors do the ward work. They don't have time to do as many clinics, so they don't interact well with patients. They just operate. And they end up as bad clinicians. Now, in the Netherlands, that's been solved because when you start as a consultant, you're a junior consultant. You're part of a team, and you do what you're told, essentially, for the first 4 or 5 years. That might not be attractive to the mentality of a UK-trained doctor or a doctor trained under a UK-like system, but it's going to be essential if the training hours continue to drop. Either that, or we make the juniors entirely supernumerary, and we only train them. They're not there to run the service. The ratio of junior doctors to consultants in the UK is 4.5 to 1. The ratio in the Netherlands is 1.7 to 1. Juniors in the Netherlands are there to replace consultants and not to run the healthcare system. And what's going to happen to senior intensivists if the juniors continue to have less and less experience? It's got consequences. Okay, So expect pressure on your budget and be willing to start addressing now what the major cost drivers are, and that's staffing. Don't wait for cuts to be imposed, because they won't be imposed where you want them to happen. It'll be a decision taken out with your control. I think juniors will be supernumerary in the future. I don't see any other way of training somebody in a limited number of hours to a reasonable standard where they can start work as a useful clinician. And I think consultants will have to work shifts and keep the unit running 24 hours a day, because that way the length of stay will go down, the quality of care will go up, and we'll be able to save money, despite the fact that we'll have more consultants. But then you can have 7 consultants for your 10 beds and justify having that number. Thank you.